Hello and welcome to Riverside's Heart Month lecture series. In honor of Heart Month, Riverside is excited to be presenting a new community lecture on a different cardiovascular topic each Thursday this month. Today, we will be focusing on women's heart health. Over the past few years, there has been an increasing awareness of the fact that cardiovascular disease is the #1 killer of women, but many women are still unaware of some of the unique symptoms and particular concerns about women's heart health. Tonight, we will be hearing from Dr. Alexandra Ward, who is the medical director for the Women's Heart Center. There will be a lot of information covered, but the beauty of video is you can rewind and listen again if you want to rehear any particular part. With all of that in mind, let's get right to tonight's presentation. And without further ado, I will turn it over to Dr. Ward. Dr. Ward?
Good evening, everyone, and thank you for joining to hear about heart disease in women this evening. The title of our talk is Not All Hearts Are Created Equal, Understanding Heart Disease in Women, which I think is so important, especially as February is Women's Heart Health Month. So let's go ahead and get started. So first, we'll define heart disease, what exactly it is we're talking about. Then we'll go through the impact of heart disease in women, why it's so important that we know about this, who it impacts, and how we can help change that impact in women. Review the risk factors, symptoms, diagnosis, how to decrease your risk, and then we'll talk briefly about the Women's Heart Center here at Riverside. So what is heart disease? It is a big topic that encompasses quite a lot of topics. So the one we think about the most is coronary artery disease or plaques in the arteries, abnormal heart rhythms or arrhythmias, congenital heart disease, meaning something that you're born with, valvular disease, heart failure, which can be both related to the pumping function of the heart or systolic heart failure, as well as the relaxing function of the heart or diastolic heart failure. Infectious etiology such as endocarditis, which is an infection of the heart valves or any hardware that might be in the heart, as well as inflammatory processes. So heart disease in women, there are a few of these areas that are more prevalent in women than in men. And those are microvascular angina. So that's an issue with the small arteries in the heart causing what we could think of as typical angina, or that symptom of chest pressure, heaviness in the chest. An entity called MNOCA, or myocardial infarction with no obstructive coronary artery disease, which is just a big fancy way of saying there's no big obstructive blockage that we can fix, but there is something that has caused damage to the heart. Microvascular dysfunction falls into this category. Spontaneous coronary artery dissection, or SCAD, falls into this category. Takotsubo cardiomyopathy, otherwise known as the broken heart syndrome, and then coronary artery vasospasm. So while all of these entities occur in both men and women, they are more prevalent in the female population. So why do we care about heart disease in women, and why are we specifically talking about it just in the female population this evening? Because heart disease is the #1 cause of death in women. And most people are not aware of that fact. In 2017, there were almost 300,000 deaths from cardiovascular disease in women. That's 1 in 3 women dying from heart disease. So if you think of your mothers, your sisters, your daughters, your wives, 1 in 3 women will die from heart disease. And 1 woman dies every minute from heart disease. So during this talk, think of how many women that would be. 1 in 3 women have some form of heart disease, and that is some of the things we've spoken about, as well as vascular and stroke. 1 in 16 women over the age of 20 has coronary artery disease. And I like to highlight that because we normally don't think about young women having heart disease, but in fact, young women do have heart disease, and when they have heart disease, they have worse outcomes than older women do. 6.6 million women are currently living with some form of heart disease, and more women die every year from heart disease than men. So it is a huge issue in women and something that's very under-recognized. So that's why it's so important that we talk about this and we educate ourselves about this topic. So here's just the trend that goes to 2009 of cardiovascular disease deaths for men and women. You can see that we've made great strides in preventing heart disease deaths. The dark blue is men and the light blue is women. But what you will see is from around 1985 until the present, more women died every year from heart disease than men did. And more women are still dying every year from heart disease than men are. Again, we've made strides and we've made improvements, but we still have some work to do. So the impact of heart disease in women, and again, why we talk about this and why we care, is that only 44% of women are aware that heart disease is the leading cause of death in women. And that number has actually gone down. The American Heart Association recently did a study about this, and it actually showed from 2009 to 2019, the awareness of the impact of heart disease in women actually decreased. Less than 25% of women recognize traditional risk factors for cardiovascular disease, such as hypertension and hyperlipidemia, or high blood pressure and high cholesterol. And less than 50% of women knew the symptoms of heart disease. So I hope with this talk today that we can change these numbers and bump all them up. So risk factors, we're saying, okay, we know that this is very impactful for women, so what can we do about it? Who should be thinking about this? And what we should be really focusing on? So there's two types of risk factors that I'd like to review today. One are the traditional risk factors, what we normally think about when we think about risk factors for heart disease, and these are shared by both men and women. And then we'll focus on female-specific risk factors. So the traditional risk factors are smoking, high blood pressure, diabetes, obesity, and dyslipidemia or elevated cholesterol. Now, when we think about these risk factors, it in fact turns out that while they're shared by both men and women, if women have these risk factors, they actually have a higher risk of heart disease or developing cardiovascular disease than their male counterparts. So they're actually even more impactful in women than in men. So let's go through them each. Smoking, most preventable cause of death in women, as well as the leading cause of heart disease. I'm sorry, it's the most preventable risk factor in women, as well as the leading cause of heart disease in women less than 50. There's a dose-dependent relationship, so the more you smoke, the higher the risk, and secondhand smoke also increases this risk. High blood pressure or hypertension is actually more common in women than men over the age of 55. And the risk for developing heart disease if you have high blood pressure is 36% for women versus 19% for men. So again, women who have high blood pressure have a higher risk of developing heart disease than men do. And that risk increases threefold if the blood pressure is very elevated. Diabetes. So women have some protection against heart disease until they go through menopause. And that's due to estrogen circulating. However, if a woman has diabetes and has not yet gone through menopause, diabetes actually removes that female protection against heart disease. And there's a threefold increase of developing heart disease in women. Obesity, a BMI greater than or equal to 40 actually increases the risk of death from heart disease in women. And this is thought to be due to a variety of factors. One is the metabolic syndrome. So obesity is related to the metabolic syndrome, and the risk factors associated with metabolic syndrome are all going to increase your risk. And that is, again, obesity and changes in lipids. There's also a relation to polycystic ovarian syndrome, which we'll get into in the next topic. So dyslipidemia or abnormal lipids. 48% of women over the age of 20 have a total cholesterol greater than or equal to 200. And so we would argue that total cholesterol should be less than 200. So that's almost half of women over the age of 20 have cholesterol that is too high. 32% of women have an LDL greater than or equal to 130. And the ideal LDL really is less than 120. And often we would say the lower, the better. Cholesterol levels do increase after menopause. HDL, or that good cholesterol, inversely predicts heart disease in women. So the higher the HDL, the lower the likelihood of developing heart disease. And then having high triglycerides increases the risk of heart disease by 37% in women versus 14% in men. So again, women who have high triglycerides have a greater risk of developing heart disease than men who have the same risk factor. So here's just an overview of everything we talked about with diabetes, high blood pressure, high cholesterol, obesity, smoking, and then also physical inactivity. So these are the traditional risk factors. These are the things we normally think about when we think of what increases your risk of heart disease. But we know that women who have these risk factors have a higher risk of developing heart disease. So it's very important that if you have any of these risk factors, that you and your physician and providers are very aggressive about treating these risks. So having good sugar control, good blood pressure control, good cholesterol control, having heart healthy weight, and doing physical activity as tolerated. And of course, always stop smoking. So now that we've talked about the traditional risk factors and why there are traditional and impact both men and women, how they actually impact women slightly more than our male counterparts, let's talk about risk factors that are specific to women. So I always like to say women's hearts are different than men's, and let's review a little more. So again, on the left are those traditional risk factors we spoke about, and on the right of the slide are more emerging non-traditional risk factors. And those are related to cardiovascular complications of pregnancy, issues related to fertility, as well as some treatments such as breast cancer treatment. So for the cardiovascular complications of pregnancy, those are the hypertensive disorders of pregnancy, which we'll review, preterm delivery, small for gestational age, and gestational diabetes. In addition, autoimmune disease is a risk factor for women for developing heart disease, some breast cancer treatments, and depression and anxiety. So we will review these each. So we did talk about PCOS, or polycystic ovarian syndrome. This is an independent risk factor for heart disease in women, and this is due to the changes in estrogen levels and the hormonal changes. There's an increased risk of metabolic syndrome, which we did talk about being increased risk for heart disease. And that risk is even greater if menstrual cycles are irregular, and it's the highest if menstrual cycles are very irregular. There's an increased risk of having blockages seen on cardiac catheterization. So that's the angiographic cardiovascular disease. We can see plaque formation, increased risk of coronary artery calcification. And so this risk, so we say, why does PCOS cause this? It's the mixture of that metabolic syndrome as well as the hormonal dysregulation. Menopause. So again, women are protected from heart disease for the most part until they go through menopause. Again, we spoke about if you have diabetes premenopause, that removes that protective risk. And if you have multiple of those risk factors that we've spoken about that are not well controlled, the risk, of course, is going to go up. So women's risk of heart disease becomes that of men after menopause, because again, that protective estrogen levels are decreasing. There's an increased risk, of course, if there's early menopause. If it's surgical versus natural, meaning hysterectomy, the ovaries were removed, so a total abdominal hysterectomy, that risk is going to go up even more. And it's due to loss of ovarian function resulting in decreased estrogen. And so now let's move on to the pregnancy complications of heart disease. So I always like to say pregnancy is nature's best stress test. So there are some complications or events that happen during pregnancy that do put women at increased risk for heart disease later in life. So those are those hypertensive disorders of pregnancy, which we'll review, gestational diabetes, preterm birth, which is before 37 weeks. And so I love this slide because it really breaks it all down, shows us the risk and shows us what we can do. So it's very important to talk to your providers, your physicians, your OBs, your primary care doctors, and your cardiologists about these risks if you've had them. So the cardiovascular complications of pregnancy fall into the following. The hypertensive disorders are the most common, and they're broken down into 4 types of hypertensive disorder. So one is chronic hypertension, then gestational hypertension, preeclampsia, and eclampsia. And we'll go through what each of those means. Gestational diabetes falls under metabolic disorders, preterm birth, and low for gestational age birth weight. So the hypertensive disorders of pregnancy, chronic hypertension is blood pressure greater than or equal to 140/90 that was diagnosed either prior to pregnancy or prior to 20 weeks gestation. Gestational hypertension is that same blood pressure greater than 140/90. That's after 20 weeks gestation. Preeclampsia is hypertension. So it's going to either be chronic hypertension or gestational hypertension after 20 weeks plus protein in the urine or signs of systemic disease. And that means changes in certain blood levels and other factors. And then eclampsia is preeclampsia, so the very high blood pressure, the protein in the urine, changes that we can see in laboratory values, plus seizures. The long-term implications of these disorders of pregnancy put women at an increased lifetime risk of the following. So hypertension, elevated cholesterol, metabolic syndrome, coronary disease, stroke, peripheral artery disease, endothelial dysfunction, and blood clots. So as you can see, it's increased risk of quite a lot of cardiovascular disease from just having a hypertensive disorder of pregnancy. And often the blood pressure does go back to normal after delivery. So while you want to say, oh, well, it just happened during pregnancy, and I haven't had high blood pressure since, it is still something that happened that should not have happened and does show us that there is increased risk of heart disease moving forward. And then preterm delivery and small for gestational age. So both of these are also related with an increased risk of heart disease in the future. And the birth weight predicts maternal lifespan. So low birth weight is associated with an increased risk of ischemic heart disease or due to a blockage in an artery, heart failure, hypertension, cor pulmonale, and lower HDL levels. Now let's talk briefly about gestational diabetes. The prevalence is about 2 to 11% of women who are pregnant. It's diagnosed after a glucose tolerance test, and there's 3 ways that those tests can go. One is it's a normal tolerance, and so there is no gestational diabetes. There's gestational impaired glucose tolerance or actual gestational diabetes. And it has to do with the failure of the pancreas to respond to the progressive insulin resistance that is found during pregnancy. So all forms of impaired glucose tolerance lead to increased risk. So even that gestational impaired glucose tolerance that isn't diagnosed as gestational diabetes does increase risk. Of course, it will increase your risk of developing diabetes and the metabolic syndrome, all of which we know are risk factors for heart disease. So we reviewed the risk factors for heart disease in women, both the traditional and the non-traditional risk factors. And so if you've had any of these, it's definitely important to talk to your physicians and your providers about those risk factors and what you can do to mitigate risk, because the best thing we can do is to prevent heart disease from happening. So then we say, so what are the symptoms of heart disease in women? We know that less than 50% of women are recognizing these symptoms. So the most common symptom of heart disease, and what I'm talking about now is blockages in arteries, so heart attack in women, is chest pressure. The feeling of an elephant sitting on your chest or somebody sitting on your chest. Most people won't describe it as pain, but they will describe it as a pressure sensation. It can also present as a pain or discomfort in the arm, the neck, the back, the jaw, or the stomach. Can be associated with feeling nauseous, hot and sweaty all over, feeling like you have indigestion, back pain, or extreme fatigue. And so sometimes you'll hear that heart disease or heart attacks present differently in women. And what we mean by that is, again, the most common symptom is actually chest discomfort or that chest pressure, but it's often associated with these other symptoms. So there's a constellation of symptoms that women are experiencing. So in addition to chest pressure, they're feeling short of breath, hot and sweaty, nauseated with maybe some indigestion and back pain. And sometimes it's hard to piece apart what's actually happening or to put this all together and say, wait a minute, all of these symptoms are actually related to one thing that's going on. So that's what we mean when we say that heart disease can present differently in women. So it's very important to know what this means, to know these symptoms, and to say if you feel these symptoms, to definitely seek medical attention. So here's a nice slide that puts that all together for you, the symptoms of heart disease in women and being our own heart heroes and making sure that we're really standing up for our health. And so how do we do that? By knowing the heart attack symptoms, and those are what we went over. Also, dizziness or lightheadedness is associated with it. Knowing the risk factors unique to women that we've gone over as well. And of course, remembering that heart disease is the #1 killer of women and causes more deaths each year than cancer, including breast cancer. So very important to know about, very important to talk to your provider and physician about. Okay, so we've talked about the risk factors, we've talked about the symptoms, and now let's talk about diagnosis. So how do we diagnose heart disease? And that can be both ischemic heart disease, heart attack, or any of the heart disease that we referred to earlier. So the most important is a comprehensive history and physical. So talking to your doctor or your provider about the symptoms you're having, your risk factors, and what's been going on. Sometimes we'll do EKG, laboratory work or blood work. Cardiac imaging is sometimes appropriate, again, based on your symptoms and what's going on. And that could include echocardiogram, cardiac CT, cardiac MRI, or coronary artery calcium score. Stress testing is sometimes indicated as well, and there are various different types of stress tests. And then occasionally cardiac catheterization would also be indicated. So these are all the things that we can do, and not everyone needs all of these things done. These are just the tools in our box to say, okay, what's going on? How can we better diagnose what's happening? So how do we decrease our risk? Again, the biggest way that we help prevent heart disease from happening is, of course, prevention and decreasing risk. So the biggest thing is knowing your risk factors. So I hope in going through the traditional and the female specific risk factors, we really have given you a better understanding of what the risk factors for heart disease are and what potentially your risk factors are. So talk to your doctor or provider about those risk factors and say, okay, if I have these risk factors, what are we doing about them? Are we meeting our goals? Are we being aggressive about really mitigating that risk? Some ways to also help are a good heart healthy diet. And I always hate the word diet. I should have written heart healthy eating. So it's really a good heart healthy eating plan. So lean proteins, whole grains, fresh fruits and vegetables. And of course, if you have diabetes or any other concerns, do talk to your physician or provider prior to changing your diet. Exercise as tolerated, which is wonderful. Even walking 20 to 30 minutes a day does help improve your risk. So you don't have to get out there and run a marathon, but just being active by walking is very impactful. And of course, risk factor modification. What we mean by that is being aggressive about making sure we're hitting all of our targets for those risk factors. So wonderful blood pressure control, cholesterol control, sugar control if you have diabetes, and of course, stop smoking. The biggest thing you can do for your health is to stop smoking if you are. And blood pressure control, cholesterol, and sugar control sometimes do require medications, so ensuring that you're taking those medications if you've been prescribed them, and making sure that you're following up with your doctor or provider regularly to ensure that the medications are still doing what they're supposed to. And so then let me just end with the Women's Heart Center here at Riverside. We see the following patient population: women who are currently pregnant, who have any of the below, so palpitation, shortness of breath out of proportion to being pregnant, chest pain, or any history of prior cardiovascular disease. Patients who've had the following cardiovascular complications during prior pregnancies, and this could be pregnancies 20 years ago. Again, those risk factors are always present. Once you've had one of these cardiovascular risk factors occur during a pregnancy, your risk is always elevated. So that's that gestational hypertension, preeclampsia or eclampsia, gestational diabetes, preterm birth, small for gestational age, or peripartum cardiomyopathy. So we would see any of those patients at any time after or during pregnancy. In addition, we've talked about those specific cardiovascular diseases that are more prevalent in women. So we do focus on those, which is spontaneous coronary artery dissection or SCAD, vasospasm, microvascular angina or microvascular dysfunction, sometimes referred to as cardiac syndrome X, the Takotsubo cardiomyopathy or broken heart syndrome, Minoka, or even a family history of premature cardiovascular disease. So we really do focus on comprehensive treatment and prevention, because again, prevention is really key. We can treat anyone who has heart disease, of course, and we'll be very aggressive about treating heart disease, but if we can prevent heart disease, even better. And so here is the team at the Riverside Women's Heart Center. That's me on the left. And then the two nurse practitioners that work very closely with me, it's Donna and Rachel. We are a wonderful team who work together to really ensure that we're providing the best care for all of our patients. So I hope that you have learned about women's heart disease, the risk factors, knowing what your risk is. And that I hope that we have moved that bar up in terms of the women who, one, know that heart disease is the number one killer of women, that it impacts all women regardless. And hopefully, we've now raised that 46, 48% of women knowing about heart disease to that greater than 50% mark, because it really is so important knowing your risk, knowing your loved one's risks, and making that impact to help prevent heart disease in women.
Thank you very much, Dr. Ward, for sharing all of this with us this evening. It has been enlightening, and it has certainly helped all of us focus on the unique risks and different ways women can experience heart attacks and cardiovascular disease. I hope everyone has enjoyed the presentation, and I hope people have had the chance to listen to our 3 other Heart Month lectures that we have hosted this month. Please keep an eye out for future health lectures that we will share on Riverside's various social media outlets and on riversideonline.com. Thank you again for joining us, and I hope you have a good evening. Good night.